Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of congenital adrenal hyperplasia caused by 21-hydroxylase deficiency. This is the most common cause of ambiguous genitalia in newborns and a true pediatric emergency in its salt-wasting form. We will work through 12 carefully designed clinical cases covering newborn presentation, the steroidogenesis pathway, physical examination and Prader staging, newborn screening, disease classification, diagnostic workup, initial and emergency treatment, the non-classic form, long-term complications, surgical management, and genetic counseling. Let us begin. Question 1. A 5-day-old female is brought to the emergency department with poor feeding, vomiting, and lethargy. Physical examination reveals mottled color and signs of dehydration. Laboratory studies show sodium of 128 milliequivalents per liter, which is low, potassium of 6.8 milliequivalents per liter, which is high, and glucose of 45 milligrams per deciliter, which is low. Examination also reveals hyperpigmented skin and ambiguous genitalia with clitoromegaly at Prader stage 3. What is the most likely diagnosis? Option A, congenital adrenal hyperplasia, 21-hydroxylase deficiency, salt wasting type. Option B, androgen insensitivity syndrome. Option C, Turner syndrome. Option D, congenital hypopituitarism. The correct answer is option A, salt-wasting congenital adrenal hyperplasia. This is the classic picture in a 46XX newborn with ambiguous genitalia. The diagnosis is strongly supported by the electrolyte abnormalities, namely low sodium combined with high potassium. Hypoglycemia is also present, and adrenal crisis typically appears between 7 and 14 days of life. More than 90% of cases are caused by deficient 21-hydroxylase enzyme. This condition requires early recognition and life-saving hormone replacement therapy. Delayed diagnosis can be fatal, so a high index of suspicion is essential in any vomiting dehydrated newborn. Question 2. A pediatric resident is studying the steroidogenesis pathway. In 21-hydroxylase deficiency, which set of hormonal changes best explains the clinical findings? Option A, decreased cortisol only with normal aldosterone and normal androgen levels. Option B, decreased cortisol and aldosterone with decreased androgen levels. Option C, decreased cortisol and aldosterone with increased androgen levels. Option D, decreased cortisol with increased aldosterone and increased androgen levels. The correct answer is option C, decreased cortisol and aldosterone with increased androgen levels. The 21-hydroxylase enzyme is required to synthesize both cortisol and aldosterone, so its deficiency lowers both hormones. Because cortisol is low, there is loss of negative feedback on the pituitary, which drives a marked rise in adrenocorticotropic hormone. This excess adrenocorticotropic hormone stimulates the adrenal gland, and the accumulated steroid precursors are shunted into the androgen pathway. The result is an overproduction of androgens. This explains the 3 hallmark features: virilization in females from high androgens, salt wasting from aldosterone deficiency, and hyperpigmentation from high adrenocorticotropic hormone. Question 3. A newborn with a 46XX karyotype presents with ambiguous genitalia. Examination reveals an enlarged phallus measuring 2.5 centimeters, partially fused labioscrotal folds, a single perineal opening, marked hyperpigmentation, and the urethromeatus opening at the base of the phallus. Using Prader staging, how would you classify this degree of virilization? Option A, Prader stage 1. Option B, Prader stage 2. Option C, Prader stage 3. Option D, Prader stage 4. The correct answer is option D, Prader stage 4. Prader staging describes the degree of virilization of external genitalia in affected females. Stage 1 shows clitoromegaly only. Stage 2 shows clitoromegaly with partial fusion of the labioscrotal folds. Stage 3 shows further fusion with a single perineal opening, the urogenital sinus. Stage 4 shows a more severe degree, with the urethromeatus opening at the base of the phallus. Stage 5 represents complete male appearance. Prader staging is important because it guides surgical planning and helps predict prognosis. Question 4. A 3-day-old male infant has an elevated 17-hydroxyprogesterone on newborn screening measured at 185 nanograms per deciliter. The infant appears well, is feeding normally, and has normal electrolytes. Importantly, this baby was born at 30 weeks gestation and weighs 1,200 grams. What is the most appropriate next step? Option A, start hydrocortisone and fludrocortisone immediately. Option B, repeat the 17-hydroxyprogesterone measurement, adjusting for prematurity and gestational age. Option C, order an immediate adrenocorticotropic hormone stimulation test. Option D, reassure the parents and discharge with routine follow-up. The correct answer is option B. Repeat the 17-hydroxyprogesterone measurement, adjusting for prematurity and gestational age. Preterm and sick infants commonly have falsely elevated 17-hydroxyprogesterone levels because of immature adrenal enzymes and stress. This baby is well, feeding normally, and has normal electrolytes, so immediate treatment is not justified. The correct approach is to use gestational age-adjusted and birth weight-adjusted reference ranges, and to confirm with second-tier testing using liquid chromatography with tandem mass spectrometry, which greatly improves specificity. Only if the adjusted value remains elevated would we reevaluate fully for congenital adrenal hyperplasia. Question 5. A 3-week-old infant with confirmed 21-hydroxylase deficiency has normal serum electrolytes, with sodium of 140 milliequivalents per liter and potassium of 4.2 milliequivalents per liter, and normal blood pressure. Plasma renin activity is mildly elevated. The 17-hydroxyprogesterone level is 12,500 nanograms per deciliter. Which form of congenital adrenal hyperplasia does this infant most likely have? Option A, salt-wasting classic congenital adrenal hyperplasia. Option B, non-classic congenital adrenal hyperplasia. Option C, simple virilizing, non-salt-wasting classic congenital adrenal hyperplasia. Option D, 11-beta hydroxylase deficiency. The correct answer is option C, simple virilizing, non-salt-wasting classic congenital adrenal hyperplasia. This form accounts for roughly 25% of classic cases. These patients retain enough aldosterone synthesis to prevent a salt-wasting crisis, which is why this infant has normal sodium and potassium and normal blood pressure. The markedly elevated 17-hydroxyprogesterone at 12,500 nanograms per deciliter confirms the classic rather than non-classic form. Simple virilizing disease presents with virilization in females at birth and with signs of androgen excess in both sexes later, including advanced bone age. The mildly elevated renin can be a subtle clue, but does not amount to overt salt wasting. Question 6. A 2-year-old child presents with premature pubarchy, advanced bone age, and accelerated growth velocity. Cortisol is low normal, while androstenedione and dehydroepiandrosterone sulfate are elevated. The initial baseline 17-hydroxyprogesterone is 850 nanograms per deciliter. What is the most appropriate next test to confirm the diagnosis? Option A, morning cortisol level alone. Option B, adrenocorticotropic hormone, or cosintropin, stimulation test. Option C, abdominal computed tomography scan. Option D, karyotype analysis. The correct answer is option B, the adrenocorticotropic hormone, or cosintropin, stimulation test. This test is the gold standard for equivocal cases. In the standard